for having Thank you for having me. I am happy to be with you guys. I'm sad that you took my friend Melissa. She used to work with me at Children's, and she's a wonderful, wonderful person, and you're very lucky to have her. So today we are going to be talking about croup. I put the title of the slide is "What's the Scoop on Croup?" So hopefully I have some newsworthy information for a common diagnosis that I know that we typically see at Cincinnati Children's, and I'm pretty sure you guys probably do too. So we'll go ahead and start. That's my slide here. And let me get to sorry, my slides are not advancing. It's been a while since I've done Zoom, so I apologize. We usually do it on Teams, so.
Randy, if you would like, if we can't get it, I know that it was
Oh,
advancing
there
when
it
we.
is. I got it.
Oh,
I got it. I got it.
perfect.
I was like, oh, there it is. Okay, so objectives for today. Hopefully, you'll be able to define croup. I'm going to give you some diagnostic criteria to use. We'll talk about the etiology behind croup, differential diagnoses that you may consider when these patients come in, and then management or treatment of croup as well. Hopefully this soundbite works, but this is a case study that I have. So a previously healthy, vaccinated 12-month-old female is brought to the emergency department by her mom for a primary complaint of barky cough. You'll hear this a lot when they come in. So mom reports that she started having a runny nose yesterday with a low-grade fever, and then this afternoon she woke up from a nap and she sounded like this. So hopefully this works. And that's the classic sign you'll hear. That's why I have this picture of the seal on there because a lot of people describe it as like a barky seal type sound, and that's typically what you'll hear when they come in. Oop, we'll move on. So what is croup? Croup is an infection of the upper airway that causes partial blockage of airflow through the larynx. It may also be known as croup laryngotracheitis because of that inflammation of the trachea and larynx. There are actually two types of croup. There's infectious and there's spasmodic. Spasmodic croup always occurs at night. The onset of symptoms for this type of croup are abrupt and the duration of the symptoms is short. And a striking feature of spasmodic croup is that it's recurrent. So it happens over and over. Whereas with infectious croup, it's kind of like a one and done, or it doesn't happen as frequently as the spasmodic croup. So we're going to be talking about the infectious croup today. Um, Infectious croup is typically caused by viral etiology. So that's 80% of the cases are caused by viruses. The most common virus that you're going to see with croup is usually caused by parainfluenza. So that could be type 1, 2, and 3. And then other viruses that can cause croup can include influenza, adenovirus, RSV, enterovirus, rhinovirus, and SARS-CoV-2. There's a couple of instances where croup can be attributed to bacterial etiology, but that's pretty rare. A lot of times the bacteria etiology will be Corynebacterium or Mycoplasma. And symptoms for croup are typically mild in 85% of children that are examined. Severe croup is rare. It accounts for maybe less than 1% of cases. So who gets croup? Croup typically happens with children between the ages of 6 months and 3 years of age. The peak incidence is 18 to 24 months. Symptoms of croup. So this is typically what you're going to see a lot of respiratory symptoms that are typically associated with it. So you'll see the runny nose, you'll see cough, typically we'll have fever, hoarse cry, and then they'll have that classic whistling sound when they're breathing in, or the stridor like we saw in the slide with the seal on it. The timing of the symptoms is usually abrupt. We will usually see it worsen at night. And they really still, even though there's been several studies on this, still don't know why that is. An older review from 2008 suggested that it may be attributed to circadian rhythms, which regulate cortisol or the stress hormone, which at night can be lower, which in turn can increase the inflammation that causes a lot of these symptoms. Other factors that can cause this may be increased mucus production and sleeping supine. So, typical exam findings that you're going to find with this illness includes the stridor, which we have talked about. They may have some tachypnea. They may have some retractions, and occasionally you may see them have expiratory wheezing. And this is from swelling that's happening below the glottis. So the table that I have here is called the Wesley Croup score. This is not a universally accepted classification method. I know I don't believe we use it at Children's. I don't know if you guys use it at Norton's or not, but typically we'll that's kind of how some of the hospitals will classify whether the patient is having mild, moderate, or severe croup. So in mild croup, the patient's well appearing, they're active, they're able to take oral fluids. The symptoms are mild barking cough with or without hoarseness, and there's no stridor at rest. With moderate croup, they will present with intense barking cough, inspiratory stridor at rest, and retractions that worsen when they're agitated. That was something I was going to bring up is a lot of times with these patients, we try to do minimal with them on exam because the more interventions you do with them, the more they get upset, the more the swelling will happen. And then in severe croup, the cough is intense, it's loud, they may have some biphasic stridor. And then these patients are typically ones that will be rushed to the ICU pretty quickly. So testing. So testing for croup is typically based on your exam findings. Although there are things that you can do to rule out other etiologies. So one of these is an airway film. So that's what you see on the screen right now. That is indicated if there's concern for a differential, not limited to tracheitis, epiglottitis, or a foreign body. As you can see on the film, there is what we call the steeple sign. So that is that is usually due to the subglottic narrowing, and we call it the steeple sign because it looks like the steeple of a church. Other things you can consider if you want to rule out differentials, you may consider getting laboratory testing, including what we call a respiratory viral panel or a swab, which will rule out some of your more common diagnoses. You can get rapid RSV, COVID, flu swabs if those are things that you're considering. But again, if you don't want to make the patient too mad because that will make that swelling worsen, so try to do the least that you can to get the differential that you are looking for. As far as differential diagnoses, we can hop right into that. So the first one we'll talk about is acute epiglottitis. This is rare, but I feel like we may be seeing this more commonly now, and we can get into that. But that is caused by swelling of the epiglottitis by a bacterial infection from the H. influenza type B bacteria or Hib. So these patients are very, very sick when they come in. Usually the onset of their symptoms is rapid. They have very high fevers. They're drooling. They have difficulty swallowing. They're very, very anxious. They may have tripoding on presentation. And then if you end up getting an airway film on these patients, it will look like the slide that's up there now. So that's the thumb sign or the swelling of the epiglottis. In recent decades, epiglottitis has been rare, like I talked about, but because of immunizations against Hib. But I feel like we may be seeing this more more prominently now with the recent hesitancy surrounding vaccinations. So definitely keep that on your differential. Other diagnoses that you may see, bacterial tracheitis. So this is a bacterial infection of the soft tissues surrounding the trachea. It's also very serious. These patients come in again very ill appearing. These patients, this will typically follow a viral infection where the trachea becomes susceptible to seeding with bacteria. So caused by various different bacteria, Staphylococcus aureus, strep, hemophilic influenza, or Moraxella. And these patients will start with your typical croup symptoms, but they escalate quickly to looking very sick with a high fever, nasal flaring, cyanosis, retractions, all the things that you see with respiratory distress. Other things that you may see, so peritonsillar, peripharyngeal, or retropharyngeal abscess. These are swelling infections that will happen deep in the neck spaces. So this is usually, you'll see these patients coming in with super high fevers, sore throat, they'll have trouble swallowing, they may have trismus, and they always have that hot potato voice. Other things, foreign bodies, definitely something to consider, especially in your toddler, even older children may get things, put it in their mouth, swallow it, and then gets lodged in that upper airway, causing them to have stridor. Um, Other things to consider, anaphylaxis. You'll see symptoms with anaphylaxis that are typically associated with that are swelling of the lips or tongue. They may have that rash. Again, trouble swallowing, and again, stridor. And then other things to consider, upper airway injuries. So this may include smoke, thermal, or chemical burns. So how do we manage these patients? So we'll start out with the mild group. So if you're using that Wesley scoring system, that's going to be a Wesley Croup score of about 2. So these patients have more minor symptoms coming in. This is largely supportive care. You're going to encourage a lot of fluids with them. The main goal is really to cut down on the inflammation that's happening. So lots of fluids, antipyretics like Tylenol or ibuprofen based on their age. And then a big one is exposure to cold air. So we'll tell patients just open up a freezer door, have them breathe that in. Or you can do a cool mist humidifier. Unfortunately, now you can't go outside where you can breathe it in cool air. But in the wintertime, when it's very cold outside, you can just take the patients outside and just have them breathe in that cold air. Other things that you can do, they can have exposure to steam from hot shower. So just turn the shower on hot, sit them in the bathroom, read a book with them, just have them to breathe in that moist air, and that'll help cut down on that swelling as well. There have been randomized control trial studies with patients with mild croup showing a single dose of steroids usually decreases the duration of the symptoms. So what we typically use is dexamethasone or Decadron. The dosing that we typically use is 0.6 mg per kg. You can do 0.15 to 0.6 mg per kg, but typically the common dose is 0.6 mg per kg. You can also do prednisolone, 1 mg per kg. Dexamethasone is usually the preferred corticosteroid because it's given as a single dose and it can be given a variety of different ways. It can be given orally, IM, IV, and so typically we'll go with that. So we'll move on to the management of the moderate to severe croup. So these are patients, if you're using that Wesley scoring system, that's Wesley Croup score of 3 to 7. So they'll have stridor at rest and mild to moderate retractions, but little or no distress or agitation. So these patients should be seen typically in the ED, or if there's an office that has that's equipped to handle acute upper airway obstruction, they may be seen there, but typically we will see these patients in the ED. So they will right off the bat get a dose of steroids. So again, they'll get that dexamethasone for one dose. And again, we try to do the least invasive method. So if they're able to swallow oral medication, we'll do oral Decadron with them. And usually you can see improvement within 2 to 3 hours after giving that. And it lasts for about 24 to 48 hours after administration. So pretty long acting. So then with the severe croup, these are patients again that are very ill appearing. So we will typically give them epinephrine or racemic epinephrine. So the way epinephrine works is it improves symptoms through arterial vasoconstriction in the upper airway mucosa, which will decrease that edema. Usually we'll give that in conjunction with the steroids because it has a quick onset of action but a short half-life, whereas the steroids will last a little bit longer. So it's nice to give them both because they work a little bit differently. So the dosing, as you can see, is 0.05 mil per kg per dose of a 2.25% solution, and it's given via nebulizer over 5 to 15 minutes. And the dose can be repeated every 15 to 20 minutes. I will say if they're requiring frequent doses, then they need to be likely admitted to the ICU. Typically, the way it works with in our ED department is that if they're requiring 2 doses within a short amount of time, they will be admitted to our hospital medicine service just because we like to observe them for rare but associated side effects. So we'll put them on typically on continuous heart rate respiratory monitoring just to keep them under observation. And as long as they do not require another racemic epinephrine treatment within 6 hours, they can be discharged to home. So severe croup, again, if they are going to up to the ICU, typically what they'll do is start them on Heliox. So Heliox is for the patients that just don't seem like they're responding to that racemic epinephrine. So Heliox is a gas mixture of oxygen and helium. It's lower density and viscosity, which reduces the resistance and airflow through those narrow airways. Again, it's used in the ICU settings. There is limited evidence with conflicting results for Heliox, but I feel like it's something that if racemic epinephrines don't seem to be working, they will typically put patients on Heliox for treatment. And there's my references, and now I have time for questions.
Thank you very much, Randy. Any questions? All right. I will take the silence as no. Thank you for this fantastic presentation. We will be posting this to our YouTube channel so people can reference back to what you have presented here and if need be, get those references as well. So thank you very much, and everyone have a fantastic rest of your day.
Thanks, you too. Thank you.